I'm the Improvement Director for ImproveCareNow, and I am absolutely delighted to be joined by Shellie Doub, who is the parent partner at Dayton Children's Hospital and who's also involved with ImproveCareNow at the network level in various ways. We are really excited, and I'm going to go ahead and mute you guys because I am getting background noise. We are very excited to bring this training, which is part of the engagement series, to all of you. And I particularly, the quality improvement methodology is particularly close to my heart, both because of my role as improvement director, but also because I think by understanding quality improvement and being able to dive in and work on quality improvement, it really enhances your opportunities to partner with your local care centers and indeed with ImproveCareNow on the national level. So in any case, what we are going to do, and again, we'll have a little bit of a compressed time frame because, again, I'm not sure if there is a technical issue with everybody joining kind of at the same time a little bit late. But in any case, I'm thrilled you're here. And we're going to start with some very brief introductions. I will then give an overview of the model for improvement, and Shellie will be helping me with that, giving the parent perspective and really speaking to how it works for parents to dive in and be part of quality improvement activities at their care centers. And then we will have some kind of interactive exercises just to help reinforce some of the things we've talked about, but also hopefully to get you kind of excited about quality improvement. So our goals for you, as I alluded to earlier, are we hope you'll be able to effectively partner with your care center's improvement team. Now, it takes people, you know, in the real world, it does take people quite some time to really learn and gain expertise in quality improvement. So please know that this is only a primer. This is kind of the introduction, the cliff notes. But I feel very strongly that even with the cliff notes and understanding some of the language, it becomes again, easier to dive in and work with your care center. We also hope, like I said, that you'll be able to participate in national ImproveCareNow quality improvement activities if that is indeed what you want to do. And I hope, as Shellie is doing right now as a patient leader and a parent leader in the network, that you'll be at a point where you're able to design and launch your own QI projects or suggest QI projects to your care center and really be the one to get the ball rolling. So I have high hopes, and again, this is just the start for some of you, but we really want to give you a good start. So if you could take a moment and just type in the chat box for me the answer to this question. Again, I apologize that I'm going to have to keep you muted because we're getting a fair amount of background noise. Do you have experience with quality improvement, either in your professional life or in a volunteer capacity, or even already with ImproveCareNow? I'll just give you just about 30 seconds to type in if you have experience and maybe a little bit about what that is. All right, so let's see what folks are typing. Okay, a couple of people typed yes. Somebody, let me just see, somebody raised their hand to speak up. All right, anybody else want to add in the chat box whether they have experience with quality improvement? All right, well, let's keep going. So before I dive in with the methodology, I want to give Shellie a chance to say a couple of words about, you know, her story, just by way of introduction for how she started to work with her care center, and maybe a few words about why quality improvement was kind of a good way for them to come together. So Shellie, I think you have yourself muted. I think you'll just have to hit unmute.
Hello, everyone. So I have been at my care center about 1.5 years, and I actually work with many groups throughout the hospital, including our hospital-wide advisory council and our sickle cell council and our diabetes council, and of course our inflammatory bowel disease council, because I'm the mom of 2 kids with IBD. And what I'm seeing is a whole movement across hospitals throughout the country towards involving parents in quality improvement initiatives. Everything from quality projects that work at making children safer, making processes easier, so for registration and access and billing. Two, the kinds of things that we've been doing with the engagement community at ImproveCareNow, which is trying to help families understand more about ImproveCareNow and get more involved and engaged with their care center, doing things like creating education days or pulling together a group of families to attend a virtual community conference.
Excellent. Thank you, Shellie. Thanks for that context. And we'll be hearing more from Shellie throughout the call as we talk about the different parts of the model. And Shellie, I will keep you unmuted on my end, just so you know, so you can also, chime in as I'm going if there's anything you want to add before we get back to your part. So the model for improvement that we use in ImproveCareNow, and I did just have somebody else type in the chat box, Jane shared that she does have experience with QI at work, that she works in risk and insurance and does patient safety. So you could probably be teaching this call, Jane. Thank you for sharing that. The model that we use in ImproveCareNow is a really simple one. Sometimes people hear about quality improvement and they get concerned that it's going to be really complicated, that it's going to involve a lot of, fancy statistics, that it's going to take a lot of time, that it's going to, rely on bringing in a whole bunch of different experts. And the thing that I really like about the model that we use in ImproveCareNow is that it couldn't be more opposite. Certainly you have to have some expertise, you have to commit to learning it, but in many ways the model that we use is how we all learn to walk. You try things out and you learn from trying. Now, certainly we did adapt this model from other industries. Probably about 15 years ago, the Institute for Healthcare Improvement in Boston decided that that healthcare was ripe for improvement. Many others did as well. But they decided that they needed to create a model that would really resonate with clinicians. And so they took sort of the best of quality improvement from engineering and business and some other industries, aviation, and said, how do we make this simple and meaningful for clinicians? And what they ended up with in partnership with an organization called Associates in Process Improvement is simply called the Model for Improvement. And the Model for Improvement it's really beautiful in its simplicity. It really walks care teams through answering 3 questions. When they identify something that they need to improve in their clinic, they have to sit down and answer these questions as a team. What are we trying to accomplish? So what is our aim? I like to say, what would we like to say that we can't say today about our system? That's a really good way of framing an aim, and we'll say more about aims in a few minutes. The second question is, how will we know that a change is an improvement? So yeah, we have an aim, but how are we actually going to know if we achieved it? We can't just say, oh, we have a hunch that we're doing better. For example, if we want to reduce our wait time in clinic before parents and patients are brought back to the exam room, you can have a pretty good idea if you're doing better, but without some data or measures, which is really what this is all about, you cannot answer that question, for sure. And then the third question, and this is the fun part, this is where I really want to encourage parents and patients on the call to think about how they can help their care teams. The third question is, what changes can we make that will result in improvement? What are the actual changes, the new ideas that we're going to test to do better? And using the example of reducing the time to getting back to the exam room, what are the things we're going to try? What are we going to do differently? And as many of you know, not all changes will lead to improvement. There are lots of good ideas out there, lots of things that work in one setting that might not work in our own. So you have to test things out, and that's the second part of this model, which is called a PDSA cycle. And again, we'll be saying more about this in detail later in the call, but a PDSA cycle guides teams through testing out these good ideas, these ideas for changes to test, testing them out in a way that they can learn whether they actually are leading to improvement. Because again, not all changes will lead to improvement. So I want to dig in first with that first question. What are we trying to accomplish? And for some teams, this can be the hardest part. I'm wondering if you can all go ahead and type in the chat box very quickly one thing that you've seen in your care setting, whether it's the ImproveCareNow team that you all see at a local care center or another sort of clinical setting that you are seeing as a patient or parent in. What is one kind of problem that you've seen that you wish could go in a different direction? So go ahead and just type briefly in the chat box for me. Not seeing any yet, don't be shy. While you're doing that, I'm going to give some examples of what aims look like. So it's really easy, again, to identify a problem, to say, you know, the wait time in our clinic is too long, or not enough patients in our ImproveCareNow center are in remission. But what a good aim for an improvement team looks like is this, and you can see the examples on the screen. ImproveCareNow has network level aims, including this one. 83% of patients across the network will be in remission by the end of 2019. Participating care centers will have their own aims. For example, Nationwide Children's Hospital might say 80% of our patients will be in remission. Or Dayton Children's Hospital might say 75% of our visits will involve pre-visit planning. That's a very different thing from saying, in a kind of general way, we have a problem. Too many of our patients are not in remission. It's actually stating the extent to which you want to improve that. And so aims are really, they become the North Star for teams. What are we shooting for? The best aims are SMART aims. Jane, you probably know this from your improvement work. SMART stands for the following. They're specific, so they're clearly stated. It is not ambiguous. Everybody sitting down and looking at the aim knows exactly what they're working towards. They're measurable, so there's actually a numeric target. And in the examples I just shared, you know, imagine if a care team sat down and said, our visits are going to get pre-visit planning. Well, it's one thing to have some visits get pre-visit planning, you know, 10% of visits. It's a whole different thing for it to become the normal way that work is done in a clinic, which might mean that you have an aim that 75% of visits get pre-visit planning. So that numeric target is extremely important, and it also becomes a rallying call, really getting people excited about what you're shooting for. It's actionable. It's something your team can actually work on. So if you can imagine a GI team working to improve care for IBD, they probably should not choose an aim around the kid's lungs, right? So you want an aim that you can move. The GI team probably wants an aim related to GI care. So something actionable, something within the control and influence of your team. Similarly, a team working in an ImproveCareNow center to improve IBD care probably will not be the right team to take on improving safety hospital-wide. So again, something that's actionable and within this team's influence. Something that's relevant, so something that can be aligned to the organization's goals. You know, certainly working to work on something that is counter to what the organization believes in can lead to a lot of barriers. And finally, something that's time-bound, so has a specific time frame. So these are some real examples from ImproveCareNow centers. The ones I showed you before were just kind of framing the aim issue, but these are some really nice examples, and I think these are all SMART aims. Sorry, 80% of patients will be in remission by January 1st, 2019. By June 30th, 2018, we will have 100% of patients with a documented visit within the last 200 days. By September 30th, 2018, we hope to have 50% of pre-visit plans to the providers before the patient's visit. Wouldn't that be nice, having the information they need when they need it? So I think these are SMART aims. I would love to hear if you disagree, but I think for the most part that they kind of hit the nail on the head there. And so Jane did type in the chat box while I was talking, when I had kind of tried to solicit a problem that we could turn into an aim. Jane had typed, not a big problem, but I've mentioned I'd like to see diagrams of anatomy in the clinic to be shown where my child's disease is. I've had to figure that out on my own. So I really like that example. And in thinking about, you know, how would an ImproveCareNow team take that and turn it into an aim that they could actually work on? Perhaps it's something like 75% of parents will state that they understand where in their child's GI tract their disease is. So instead of saying that I want to have a diagram, which is an example of a change to test, you're actually stating what the outcome should be. And Jane, I'd love to have you type whether that makes sense to you. So again, you've stated a problem And I would go about developing an aim by thinking about what the ideal state would be. And again, I think that's what you're alluding to, that patients and parents have some knowledge that they don't know now. So Shellie, I have your slide up with your reflections about aims. If you could just share those. I know I think you're still muted. So if you could go ahead and just talk about what aims have meant to you in your work with your team.
Sure, I can do that, but I'm going to confess to everyone that I'm really fairly new at this QI stuff. And so I'm going to be learning alongside all of you tonight. I do think that one of the benefits of developing a SMART aim is that it can help your advisory board decide with your team which projects to tackle. I sit on a lot of advisory councils, and we come up with many ideas, some of which are actionable and others are not, or need to at least be tabled for a while. And I think that the SMART aim will really help you to present an idea and demonstrate that benefit to your care center so that you can get buy-in from your team, which is one of the biggest hurdles that parent advisory councils tend to tackle. I'll give you an example of something that we have done here at Dayton Children's. So back in June, we were part of an engagement initiative with ICN, and we decided to hold a virtual watch party for the ICN Virtual Community Conference. And we really didn't do a whole lot of advertising or anything. We just let our family advisory council show up. And I think we had maybe 5 or 6 parents that evening. When the next when the next virtual conference was coming up, we decided that we wanted to try to double that number of parents. And so we sat down together, and our aim was to double the number of parents who would be at the community conference. We shared this with our team, and we shared some very specific steps for getting there. And that will, I think, come a little bit later in Sarah's presentation about how you develop those steps. But we actually ended up having, I think, 15 families at our conference in October, mostly because we did develop a SMART aim and go to our team and say, this is what we want to do, and here's how you can help us do it. I also think it creates a framework to share your learnings with others. So now that I know how to double the participation at a community conference at my center, I can share that with other centers so that they can try the same things and see if it works in their community. And they may find that it works great, or they may find that they have to go through the QI process and make some tweaks to my process so that it fits their center. And I think an example, again, I've given you the virtual community conference. We had a very clear timeline and very clear goals for our process. We only marketed for about 3 weeks in order to double the number of families that attended.
Thanks, Shellie. That's a really good example, and I think your points, you said you're a novice, but actually you're much better at this than you think, because your points were right on target. The benefits that you stated of developing a SMART aim are exactly why we do a SMART aim. So getting people to rally around an idea, getting data, and being able to tell your story to others. So thank you for that great example. So the next question in the model for improvement is, how do we know that a change is an improvement? Collaborative improvement is about changing the approach to improving the health of patients. It is not about measurement. Some people, again, when they hear about quality improvement, they think, oh, we're going to set up all kinds of statistical analyses. We're going to get really fancy with numbers. We're going to have beautiful charts. And certainly we do end up with beautiful charts, but improvement is not done for the sake of measurement. We like to say that if you have 10 units of energy to expend on a project, that 9 of those should be spent on testing changes and actually trying out good ideas, and 1 of them should be spent on measurement and data. However, measurement is really important, and I'd love to have you type in the chat box briefly why you think some measurement does matter. Okay, so some of the responses that we get are things like, knowing whether you got there, understanding whether the things you're testing are working. You have to be able to determine whether something is working or not, absolutely. So one quick point about the different levels at which we use measures in ImproveCareNow. So in ImproveCareNow, just like there are ImproveCareNow level aims about the whole network remission rate, the whole network improving things, ImproveCareNow has network level measures. There is a big dashboard that lists about 20 different measures that are compiled from across the 109 care centers that tell us how the care centers are doing overall. Additionally, participating care centers, those that you all take your kids to, have their own center level measures to make sure that, that they're going in the right direction. And there are different types of measures. That's another important level to think about when learning about measures. There are different types. So one is outcome measures. So that would be your results. How is the system performing? How are kids doing? And remission is the perfect example of an outcome measure. Are the changes that you're making leading to better outcomes? So things like remission, things like whether kids have better nutritional status, things like whether kids are able to go to school and not miss school during the month. Those are outcome measures. Process measures are things about how the system is functioning. So things like the percentage of visits getting pre-visit planning, things like the percentage of patients that are being seen within 200 days, which we think is important in ImproveCareNow. So it's measuring things about the system, but not necessarily things about the patient outcome. We also have something called balancing measures, kind of like robbing Peter to pay Paul. So think about it for a moment. If your clinic does some things to reduce the wait time to get back to the exam room, could there be any negative effects of that? And I'll let you type in the chat box. I'll give you a second to think about that. So on its surface, you could look at the situation of reducing wait times in the exam room and say, there's nothing bad about that. People love to get back there quickly. But absolutely, it can cause some upsets in the system if not done well. And that's why sometimes we have balancing measures. So if patients get back to the exam room too quickly, what might that do to the medical assistant's workload if suddenly everybody's back in exam rooms waiting for their vitals and they haven't thought about how to deal with that side of the system? So there would perhaps be a measure around, wait time in the exam room, but you also might need to pay attention to, does the medical assistant still have time to take a break and do her charting? Does the medical assistant state that, she's able to do things as well as she'd like, or is she overwhelmed because people are coming back so quickly? So balancing measures are a way to make sure you're not upsetting the system. These are some things we share with care centers. They're a little bit advanced, and I want to just I don't want to go too deep into them, but when a center is working on a particular improvement project, they don't want to have 20 different measures about it. They want to have sort of a balanced set of 3 to 10 measures that they track each month to make sure the system is improved. So if they are working on making sure that they're providing better IBD care, they have a balanced set of measures that ImproveCareNow recommends, a couple outcome measures like remission, a bunch of process measures like the percentage of patients who are being seen within 200 days, the percentage of patients that have all of the complete data entered that is supposed to be entered for every visit. So we really suggest the kind of measures that they use. Measures should always reflect your aim statement. You should not have measures that cannot be tied directly back to one of your improvement aims, and I'll share some examples of that in a minute. And again, measures are used to guide improvement and test changes. They're not collected just because you want more numbers to look at. Another really important principle, and this is important for parents to know as they're suggesting projects to care teams, it's really important to be able to integrate measurement into the daily routine. If you go to a care team and say, we really think you need to do a better job preparing families for transition. Here's a really fancy checklist that you're all going to need to complete to talk about whether each patient got a discussion about transition. A really long checklist is not going to be something they can build into their daily routine. Maybe adding one little sticky note to each chart and for a week checking off whether they got a discussion about transition, that's going to be a whole lot easier to integrate into the daily routine. So keeping data simple is really important. And then what we really encourage teams to do is plot their data on what we call a run chart. You know, over time, they're able to show where they began with their data, where they went over the course of several months, and then to write some notes on that graph about what they did that led to that improvement. And I'll show some examples of that. But on the screen, I have some examples of measures in ImproveCareNow. And the thing that I want you really to remember is measures are really just what happened when you flip the aim around. You don't have to come up with something really fancy. So if your aim was to have 75% of patients in remission by January 1st, your measure simply is the percentage of patients in remission by January 1st. Or if your measure was, or your aim was to have 90% of pre-visit plans to providers before a visit, your measure simply is, okay, what percentage of visits can you say that about? So I really like to counsel people that measures can be really simple, and it's just a matter of turning your aim into flipping it around so that you're making very clear that you're measuring exactly what you stated in your aim. So Shellie, I don't know if you have any quick reflections about measures or what has made it difficult or not difficult as a parent partner about being part of measurement and data collection.
I think that measurement is one of the most difficult parts of QI for advisory councils to kind of wrap their heads around and develop a process for, because many of the things that families want to implement, we just don't really see how to measure them. An example of that is that our care center right now is working to revise our new patient education packet. And, you know, our aim is to develop new education, but we had a hard time defining exactly what that aim looked like and defining measures around it. But we've been thinking, and we're still in the process of this, that once we develop the packets and we're handing them out to families, we can come up with some specific measures, like asking families if we're delivering the education at the right time, thinking about how long it takes to deliver the information, because right now we're doing it one-on-one, and it varies widely whether a family gets 30 minutes of education or an hour and a half of education based upon their needs. We might even be able to go back at the next visit after the families have gotten their education packet and ask them some measurement questions. For instance, we are going to include a diagram of the GI system and locate their disease for them. So we could ask, do you know the location of your disease? And that would help us measure the effectiveness of our new patient education. One thing that we do here at Dayton Children's, and I'm sure we didn't come up with this, but we do something called a 2x2. So whenever our measures are more qualitative, for instance, how was your experience, or how was your meal today, we tend to have a nurse or a medical assistant simply ask 2 questions that are related. So for instance, we might ask, do you know what resources are available to you? And specifically, do you know what resources are available through ImproveCareNow? Those might be a good follow-up to our new patient information package if we want to be sure that we're directing people towards ImproveCareNow.
Thanks, Shellie. Those are great points, and I think thank you for being, transparent about the fact that measurement is hard. You know, it's hard for parents and patients. It's also really hard for clinicians who are new to improvement, and it's one of the things that we spend the most time supporting them on, and one of the things that we really need to continually remind them of the key principles. So thank you for sharing that. And then the third question in the model for improvement is the one, again, that I think is the most fun. What changes can we make that will result in improvement? So in ImproveCareNow as a network, there are a couple of areas that the participating care centers are encouraged to work on improving. Obviously, it's things like patient outcomes like remission rate, et cetera. But there are key areas in which we think if they work in those areas, they will get better outcomes. And those are things like data quality and registration. So what are some new things you can do to make sure that you're collecting complete data on all of your patients? Things like pre-visit planning and population management. So the use of data to better shape improvement efforts and to make sure that you're doing things that will work for individual patients and groups of patients. And then self-management support. Things like, are you teaching patients what they need to know to do a good job of managing their own condition? So teams come to Improve Care Now conferences and webinars and think about the different things they can try in each of these areas that will help them move towards improved care. They get ideas at conferences, but they also get ideas in other ways, as do parents and patients. They get ideas from other care centers. Parents get ideas from talking to other parents as part of the parent working group or as part of maybe a Facebook group they're on, or other ways that they interact with other parents of kids with IBD. And lots of ideas are shared on what we call the ICN Exchange, which is kind of an online tool where teams post their best ideas, as well as via social media. We're very generous in Improve Care Now with sharing articles, tools, and ideas that have been created by centers so that others can take them and, as we say, steal them shamelessly. So examples of the changes that teams can test. And again, the real distinction here is that when somebody says they're going to test a change, that doesn't, a lot of times people will at first just sort of restate their aim. If I say, what change are you going to test? They might say, well, we're going to work on improving remission. That is not an actual change to test. That's not a concrete thing you can try out in your clinic. Changes to test are things like those listed here. Maybe a care center will try out a new clinic visit reminder system. Maybe they've been having trouble getting patients to make their follow-up visits, and they decided, you know what, we're going to catch them when they're in the infusion suite. Every patient coming to the infusion suite, we're going to take a peek and see if they have a next clinic visit. And if they don't, we're actually going to call from there and make their appointment. So that's a change that one team tested to work on getting patients back to clinic. Another one tested having an IBD support group to encourage sharing, support, and all that great stuff that happens when patients get together. They did that because they realized they needed to improve self-management support, but just saying I'm going to improve self-management support doesn't describe what you're going to do. So again, this team tried a support group. And another one, this is an example from an actual narrative report that our teams turn in. We're currently running a test on implementing an IBD clinic. We want to address all the needs of kids during clinic by having the whole team available. So a care team that did not previously have a dedicated IBD clinic said, you know what, this is a change we're going to test because we think it will better meet the needs and therefore lead to better outcomes. So they have ideas, you know, at any given moment in the network of 109 care centers, there are probably 40 or 50 different change ideas that are being tried out. So Shellie, do you want to share just a couple of things about how parents can kind of give feedback to change ideas?
Sure. Some things that we tend to toss around in our advisory council meetings is what is it that our center does well and how can we improve it and make it better? An example of that would be just last night we had a meeting and we were talking about billing and insurance and that sort of thing. And we realized that a lot of families don't have all the information that they need to navigate the financial side of having a child with chronic illness. So we're talking about the possibility of creating some sort of a handout or guidance or maybe something on our web page that will help to improve the way we share information about the financial side of having IBD. Another thing that we think about often is what we wish our care center offered. A parent support group is a great example of that, and it's been asked for many times, and we finally got one up and running in June, I think. However, we didn't have the resources to do that, so we partnered with our local CCF organization to make that happen. And finally, what would your care center team like to improve? parents often have ideas, and care centers have other ideas about things that meet their strategic goals or problems they see from families that call in that are perhaps less well-resourced than the families who are involved in the advisory council. So we brainstorm with our staff team to make sure that we're meeting all of those types of needs. And my best tips for you would be to start small, one very small, manageable project, like maybe figuring out how you can get people to come to a virtual community conference watch party. Pick one project at a time, and that's very hard advice for me to follow because I like to do it all and do it all at once. But that can be a little overwhelming, both for your parents, who are probably just meeting once a month, and for your care center team, who have so many competing demands for their time. And my biggest piece of advice is make sure that you have a passionate partner from your care team who is working with your families. It is very hard to drive change without buy-in from your staff, or at least from one staff member who will make sure that the things that the parents have suggested are actually happening in the care center on a day-to-day basis.
Great, thank you, Shellie. That's great advice. So we're going to have a pretty abbreviated look at the next part of the model, which is the PDSA cycle, actually testing changes and how teams go about that, because we got started a little bit late, but I still want to give you a quick introduction. And then this will hopefully be good food for discussion with your care center to be able to sit down and say, you know, I learned about the model for improvement. I heard that you use these PDSA cycles to test changes. What does that actually mean to you in clinic, and how can I help? So again, we've talked about these first three questions in the model for improvement. Then comes the testing part, the PDSA cycles: plan, do, study, act. A lot of teams want to skip this part. They do these, they answer the questions, they get to work, and they say, well, we have a really good change idea. We're going to dig in and do it. It's going to be the way we do business. Well, as most of you know, if you decide to change things overnight across a whole clinic or across a whole business or across a whole school, it can lead to a lot of heartache because people were not ready. You didn't have data to show that it actually is the right thing for your environment, and people aren't ready for that big change. So that's where PDSA cycles come in. So there are a couple of reasons that we test. We test because it will increase the belief that a change will result in improvement. If we have tested a really good idea, a really good change on a small scale, we can often convince the skeptics who didn't like the idea that it actually worked. So we can increase the belief of the whole team that it actually will be a good thing. It can allow us to predict how much improvement can be expected from a change. So right now, if I hear a good idea from Nationwide Children's Hospital, and I'm Children's Hospital of Wisconsin, and I want to test it on a small scale, testing it on a small scale helps me understand and kind of extrapolate how big of an impact it will have. If I test things out with 5 patients and it works well for 4 out of the 5, I can kind of estimate that, you know, maybe 90% of, maybe this will work for 90% of patients when we try it out on 100. So it lets us predict how much of an impact something will have without suddenly trying things with 100 patients. It lets us adapt changes to our local environment. So, you know, Nationwide Children's Hospital is a big academic medical center. Something they tried out there may not work very well in a small private practice unless they adapt the changes. And by adapting them through testing on a small scale, they learn very quickly what changes they need to make because they're in a different type of setting. It also lets you evaluate the costs and kind of the negative side effects of the change, that those balancing measures I told you about earlier. Are we making one person's job easier yet making somebody else's job harder? And again, by having some data and some stories to tell about testing, you can really minimize resistance once you're ready to spread it out and scale it up. So when a team gets a good idea, like I said, they come up with the change they want to test, they sit down and they actually have a worksheet from us that works them through these questions. The team sits down and makes a plan. What is the objective for our test? What do we think will happen and why? And who's actually going to do the work? It's one thing to say, you know, the care team is going to go test this out, but what does that mean for the role of the doctor? What does that mean for the role of the nurse? And are we going to do this on Tuesday? Are we going to do it on Thursday? This really takes away the ambiguity in how you're going to test out new ideas. Then they get to work. They carry out the plan. They learn from doing it. They document what happened. So maybe while they were trying out a new pre-visit planning process, the computer system couldn't handle the number of pre-visit planning forms they were going to print out. So they wouldn't have known to expect that unless they tested. And they sit down and they start to analyze what happened. Then they move into the study phase. The team sits down and says, okay, we collected some really simple data. We see that 75% of the visits on Tuesday actually got that pre-visit plan because of the change we tested. We thought it would be about, I don't know, we thought it would be 50%. It ended up being 75%. So what made it go well? What could we improve? Really summarizing what they learned. And then the important part happens. They decide whether and how they're going to act. So if we're going to do this again, you know, let's say it went pretty well. If we're going to do it again, what changes should we make? We learned something about how we should tweak the process. Maybe the computer couldn't handle all that printing. Maybe we need to do it differently. Or maybe it was just a disaster. Maybe it was absolutely the wrong thing for our clinic and we just need to abandon it. In which case, you go back to the drawing board, you come up with new change ideas, and you start the cycle again. So Shellie, I wonder if you could say just a quick word about testing. You have some really nice insights here. And again, testing, there's so much resistance to testing when you hear a good idea in a community like ImproveCareNow because it sounds like such a good idea. But I love some of what you have here about, you know, reinforcing why testing is important.
So I want to share an example of something we tried here at our care center. We wanted to improve the way physicians and patients were communicating. And so we developed a little card. It's like a 5x7 card, and it says, "What's on your mind?" And it has some questions for the family to fill out while they're waiting. And then the card was given to the physician so that he would know what their concerns were for that day. So we started this process in one clinic with one provider. And it took us 4 weeks of PDSA Cycle to figure out how to actually get the card to the family and collect it and back to the provider in a fairly accurate fashion. But once we figured that out and we were getting the cards to the providers, so we tested and tested and tested again to that point, then we added a second provider and a third provider, and eventually those cards were being used by all providers in all of our clinics, whether at our main campus or out in other campuses. We did that for about 3 months. Some changes that we made along the way were to the actual card itself. We decided that we weren't getting very good information on it, so maybe we should change the questions and add some check boxes and make it a little more clear. Every time we made a change to the card, we tested and tested and tested again until we got it what we thought was right. And we actually saw at the end of that about 94% of the time the cards were being given out by registration. About 50% of the time they were actually being written on and returned to the MA. The MA was 100% of the time getting them to the provider. And the providers gave us back some qualitative data saying that 3 out of 4 providers really felt like it improved their understanding of what the family wanted to know at that clinic visit. So it's a process, and we had to meet on pretty much a weekly or weekly at first, and then eventually bi-weekly basis to talk about what worked, what was making it work, and then how we could keep sharing that with other providers within the practice. Now that we feel like we've perfected this, we're trying to figure out how to share this in other clinics in our hospital that maybe have a different registration system, that maybe register for multiple clinics instead of just one. when you think about discovering what doesn't work and why, you have to ask yourself why it failed. Initially, the cards weren't getting handed out because we simply tried the wrong way. We thought that we could just attach them to the pre-visit planning forms and that they would get to every patient that way. But the reality is that not all of our physicians were consistently using those forms. So we had to go back to the drawing board and decide to use them at the registration desk at the point of entry. As Sarah was saying, sometimes you feel like waiting isn't a good thing and you want to get patients back as quickly as possible. When we worked on that in a separate improvement measure, we reduced the amount of wait time, and guess what? It reduced the amount of time families had to write on that card. So we had to rethink where in the process we gave that card so that families had plenty of time to write on it. Another example would be an ICN awareness card that program that we were passing out just to make families aware that ICN existed. And again, we found the cards were not being given by staff to the families in a consistent manner. But the only intervention that was really needed to make that happen was getting our nursing director to promote it at staff meetings and at our population management meetings. And that significantly increased the number of cards returned. So my advice is just keep looking at it. It's like a puzzle. Try to figure out what is working, what isn't working, and where you can make it better. And as you talk with your clinic team and everyone involved in the process, you'll find that there are lots of great ideas. And you sometimes don't know which one is the best one. You just have to try it and see what happens.
Thank you so much, Shellie. So we are at the end of our time. Again, we apologize for the technical issues at the beginning of the call and for getting started a little bit late. So we cannot get into kind of our interactive exercise today, but I really want to leave you with two challenges. One is what we say to every care center when they leave one of our in-person community conferences, which is what can you test by next Tuesday? So can you find a very small project, whether it's in your personal life, in your life with ImproveCareNow, where you can answer the 3 questions in the model for improvement and get started with something very small that you can test with 1 or 2 patients, with 1 or 2 carpool lines at school, whatever the case may be. And then what ideas, and this is important because as Shellie said, parents can really have some of the best ideas for improvement. What ideas do you have to share with your care center the next time you meet with them? Write them down. They want your ideas. I have seen in my 10 years with ImproveCareNow, so many ideas that came from parents and patients being implemented by care centers. What ideas do you have to share with your care center? So thank you. I'm going to leave you with this last slide. These will be put on the website, so you'll have access to these slides. There are 2 really nice videos that I think are another great introduction to improvement. One is kind of a really fun and entertaining whiteboard video on the IHI website, and the other is more kind of a text overview of the model for improvement. A lot of what we just shared with you, not with the ImproveCareNow examples, but kind of the basics of the model, so that you can go back and look for yourself and spend some time on it. So thank you so much for your time. A very special thank you to Shellie for spending her time with us tonight. And we hope you all learned something you can take back to your care center. Thanks so much, everyone.